Periodontal diseases, or also known as the gum diseases, are the infections of the structures around the teeth, which includes gums, periodontal ligament, and alveolar bone. In more severe forms of the disease, all the tissues are involved. Periodontitis is a serious gum infection that damages gums and can destroy the jawbone. It affects most people in some part of their life. According to the Australian Dental Association, almost 40% of Australians aged 55 and over reported periodontitis in the year 2004 to 2006, and the prevalence of the severe periodontitis, which was 6.6% in the year 2005, has increased to 7.3% in the year 2015. Due to its increase in the number of people affected each year, it is essential to treat them at its early stage to prevent loss of dentition. The conventional method of treatment for periodontitis varies from scaling and root planing to flap surgery depending on its severity. However, I would be comparing laser periodontal therapy with conventional periodontal therapy as an alternative treatment approach, and using randomized control trial, I would be comparing the treatment outcomes from the selected study. The selected paper clearly addresses the focused issue. The study population included people with generalized aggressive periodontitis, and only the people who matched the inclusion and exclusion criteria were considered. Inclusion criteria were good general health, radiographic evidence of interproximal bone loss exceeding 50% of the root length, probing depth of 5 mm at more than 8 sites per quadrant, age of over 30 years and below 40 years with rapid bone loss as shown by the radiographs, a minimum of 6 teeth per quadrant respectively, and a concentration of more than 10 colony-forming Actinobacillus actinomycetum comitans. The exclusion criteria were periodontal therapy during last 12 months, use of antibiotics during last 3 months, pregnancy, any systemic condition that might affect the study, previous or current radiation or immunosuppressive therapy, use of mouthwash containing antimicrobials during previous 3 months, use of hormonal contraceptives, medication by anti-inflammatory and immunosuppressive drugs, history of excessive drinking and smoking, class 2 or class 3 tooth mobility. The final number of patients assessed for eligibility was 31. The assignment of the patients to the treatment was randomized. A clinician not involved in the trial generated a random quadrant allocation sequence by a ratio of 1:1 using a permuted block designed by a computer random number generator. In every subject, the upper maxillary quadrants were allocated to receive scaling and root planing with laser, that is treatment A, and scaling and root planing alone, which is treatment B. The examiners and patients were not informed about the type of the treatment, thus avoiding bias in the evaluation of the experimental data. The operator was informed and performed one of the two types of the treatment. The same operator performed all the procedures and was blinded to the previously recorded data and did not participate in any measurements or analysis. All the patients who entered the trial were properly accounted for. After admission to the study, each patient was instructed in oral hygiene and appropriate motivation, repeated at every appointment, and underwent supragingival prophylaxis by ultrasound and hand instruments. 7 days after treatment phase 1, clinical data which included probing depth, clinical attachment levels, bleeding on probing, and full mouth plaque score were recorded in all the subjects as a median. Both quadrants included maxillary teeth from 1:1 to 1:6, that is from central incisors to first molar on the right side, and 2:1 to 2:6, which is central incisors to the first molar on the left side. The evaluations were performed at baseline and at the day 15, 30, 60, 180, and 365. The patients, clinicians, study personnel, and health workers were kept blind to the treatment to avoid bias. The study population selected remained similar from the start of the trial, closely matching the inclusion and exclusion criteria in order to prevent them from affecting the outcome. The recorded initial baseline parameters were pocket depth measuring over 5 mm, clinical attachment levels around 5 mm, bleeding on probing in around 75% of the subjects, and full mouth plaque score of around 28%. Aside from the experimental intervention, all the study population was treated equally. Each subject, after recording the periodontal parameters, underwent one of the following treatments. One maxillary quadrant was treated with scaling and root planing and laser treatment, that is treatment A, while the contralateral quadrant was treated with scaling and root planing alone. All the patients received treatment under local anesthesia. For microbiological and inflammatory evaluation in all the subjects, subgingival plaque was acquired from 8 interproximal sites at baseline and at 15, 30, 60, 180, and 365 days after the therapy. Gingival clavicular fluid was obtained from 8 other different non-contiguous interproximal sites using filter paper strips. 1B, the level of interleukin 1 beta, interleukin 10, and tumor necrosis factor alpha were measured by enzyme linked immunosorbent assay using an equation with software. The treatment effect was large, and all the enrolled patients successfully completed the study. At baseline, no significant difference were present between the groups for all the parameters. Comparison over time shows that the scaling and root planing with diode laser group significant differences existed at 60 days for pocket depth and clinical attachment level values. At 15, 30, and 180 days, there was no significant difference between two treatment for pocket depth, clinical attachment level, bleeding on probing, and plaque score values. At 1 year, both treatment produced a reduction of every periodontal parameter compared to the values recorded at the baseline. And this difference was statistically significant in scaling and root planing with diode laser group. However, at year 1, a comparison between the two treatments showed that scaling and root planing with diode laser therapy significantly reduced pocket depth by around 2.5 millimeter, and compared to scaling and root planing alone treatment, which was measuring around 3.36 millimeter, and clinical attachment level was around 3.47 millimeter compared to scaling and root planing treatment alone, which was 4.11 millimeter. Bleeding on probing was reduced, but with statistical significance around 26.16% compared to scaling and root planing alone, which was 32.26%. Of the 40 microbial species evaluated at the time of point, the scaling and root planing with laser diode treatment group showed significant reduction in 4 species of orange complex at 30 and 60 days compared to scaling and root planing alone. There was a statistical significant reduction of the mean gingival clavicular fluid values due to the treatment response in both groups from baseline to the last follow-up. However, the scaling and root planing with diode laser determined a significant reduction in the mean level of interleukin 1 beta at 15 and 30 days compared to the scaling and root planing group alone. The precision of the treatment effect was as estimated, with a significant good prognosis using diode laser adjunct to conventional scaling and root planing procedure. Similarly, the results can be applied to the Australian population. The subject population considered in this study is the mean age for the disease, and if it is controlled at the early stage, there will be a significant reduction in the percentage of the people affected by periodontitis. During this study, all the clinically important outcomes were considered. Thank you for your time.